Welcome to today's deep dive. We've got a really compelling stack of sources to go through today.
Oh, definitely. A pretty wild mix of clinical guidelines, plastic surgery textbooks, and some advanced aesthetic clinic resources.
Yeah, exactly. And the topic at hand today is labial puffing, which, clinically speaking, is the restoration of volume to the labia majora.
Right.
But our mission for this deep dive is to look way beyond those surface level before and after photos you see everywhere.
Yeah, we really want to dig into the fascinating science of the maintenance, the top-up treatments.
Exactly, because we want to uncover exactly how the human body interacts with and eventually assimilates or breaks down these enhancements over time.
Because we so often hear cosmetic procedures divided really neatly into two distinct categories, right? Like comforting
Oh,
categories.
for sure. It's always either temporary or prominent.
Right, temporary fixes or permanent solutions. We like to think of medical interventions as having this definitive endpoint, like you either rent the results or you buy them.
But when you actually step into the world of cosmetic gynecology, specifically procedures involving the intimate areas of the body, that neat little binary system just completely falls apart.
It really does. It's so much more dynamic than that.
It turns out almost everything we're looking at in these clinical texts requires some kind of top-up eventually.
Yeah.
It just depends on, well, how your individual cellular metabolism dictates the timeline.
Yeah, because your body is never just a static canvas, right? It doesn't just passively accept whatever we put into it.
Don't say.
It's this living, breathing, constantly metabolizing ecosystem, and it reacts to every single material you introduce to it. So to really understand the maintenance required for these procedures, we first have to understand the biological baseline.
Meaning we have to look at what's driving the loss of volume in the labia majora in the first place.
Exactly. Why is the puffiness going away?
Well, the clinical literature points to this kind of perfect storm of biological and mechanical factors.
Mhm.
You have natural aging, obviously, which degrades skin elasticity, and subcutaneous fat everywhere in your body.
Right, that happens to all of us.
But the primary catalyst seems to be these specific hormonal shifts. Most notably, the really significant drop in estrogen that happens during menopause.
Yeah, estrogen is huge here. I mean, it's not just a reproductive hormone. It acts as this critical chemical messenger for your skin and your connective tissues.
It's like a signal flare.
Exactly. It constantly signals the local fibroblasts, which are the builder cells in the tissue, to produce hyaluronic acid and collagen.
Which are the things that keep everything plump.
Right, those molecules are the structural scaffolding. They hold water, they keep the tissue thick and resilient. So when estrogen levels plummet during menopause, that chemical signal just goes quiet.
So the builders stop working.
Exactly. The fibroblast becomes sluggish, that whole hydration matrix collapses, and the tissue physically thins out.
And then, you add mechanical wear and tear on top of that, like the physical toll of childbirth. That actually stretches and permanently alters the underlying fascial network.
Oh, absolutely.
Plus, the fat in the labia majora behaves pretty much exactly like subcutaneous fat elsewhere in the body. So if you go through a significant weight loss, the lipid stores in those specific fat cells shrink.
Which contributes really heavily to that deflated appearance.
Right. And the sources make this crucial point that this deflation, it's not purely an aesthetic concern.
No, not at all. The outer labia actually serves a very specific, vital mechanical function.
It's a protective cushion.
Exactly. It protects the much more delicate inner structures, the labia minora, the clitoris, the vaginal introitus.
So when that outer cushion deflates, the structural integrity is just compromised.
Yeah.
And all that physical impact is transferred directly to those incredibly sensitive, nerve-dense areas underneath.
Which sounds awful.
It is. Patients describe experiencing severe chafing, micro tears, chronic pain during, everyday activities.
Like cycling or horseback riding.
Yeah, or even just wearing fitted clothing.
Mm.
And of course, friction during sexual intercourse can become incredibly painful too.
And that loss of structural protection is really what drives so many patients to seek intervention. The mechanical barrier just isn't there anymore.
I kept thinking of it mechanically, like a well-loved couch cushion.
Oh, that's a good analogy.
Right. Over the years, the dense foam inside just breaks down. The fabric on the outside might look a bit wrinkled and loose, but the real problem is that when you sit down, you immediately feel that hard wooden frame underneath.
Yeah, the shock absorption is just completely gone.
Exactly.
That visual captures the anatomical reality perfectly. The medical goal is to basically restuff that cushion, right? To restore the shock absorption.
But keeping it stuffed, that's where the biology makes things complicated.
Right, because your immune and metabolic systems don't just passively ignore new material, which is why the medical field has developed two main treatment models.
Let's start with the approach that sits firmly in the temporary category, the HA subscription model.
Right, hyaluronic acid dermal fillers, like
Yeah.
Desereal, Restylane, Juvederm.
And from a procedural standpoint, this is incredibly efficient. We're talking about a 15 to 30-minute outpatient procedure.
Yeah, very quick. They use local numbing and then inject the filler using a cannula.
A cannula, right? Not a standard needle.
Exactly. And the use of a cannula is a key detail here. Unlike a sharp needle that just slices directly through tissues and blood vessels, which causes a lot of trauma, a cannula is a flexible, blunt-tipped tube.
Oh, so it pushes things out of the way.
Right. The practitioner creates just one tiny entry point with a regular needle and then slides the cannula in. It gently nudges the internal structures and blood vessels aside as it deposits the filler.
Which drastically minimizes bruising and trauma to what is, honestly, a highly vascular area.
Very vascular, yeah.
So the patient can basically walk in, have the volume instantly restored, and walk out with practically no downtime.
Sounds perfect, right?
It does. But, our listeners probably know that hyaluronic acid is naturally occurring in the body. Its main job is to bind to water molecules for hydration.
Right.
But the HA they have in a syringe isn't exactly the same liquid-like substance floating around our joints naturally.
No, not at all. It has to be chemically modified to survive. Because if a doctor just injected raw, unmodified hyaluronic acid into your body, your natural enzymes, specifically one called hyaluronidase, would just chop it up.
Just destroy it.
Yeah, it would metabolize it in about 24 to 48 hours. It would be completely useless as a filler. So the manufacturers use a process called cross-linking.
Right, where they chemically bind the long HA molecules together, basically weaving them into a dense three-dimensional mesh.
Exactly. It creates this viscous gel. And the tighter that mesh is woven, the harder it is for your body's hyaluronidase enzymes to penetrate and break those chemical bonds.
Oh, so the engineering is what dictates the maintenance reality.
Yes. Your body recognizes the HA as a natural substance, so it constantly sends enzymes to dismantle it. But the cross-linking forces the body to do it very slowly.
So your biological cleanup crew is working around the clock, just chipping away at the gel.
Yep. And because of this continuous metabolic process, the results of an HA filler in the labia typically only last between 6 to 18 months.
Meaning, to sustain the cushion, you are locked into returning for regular top-up injections.
Right, and the specific mechanical demands of the labia require highly specialized cross-linking, too. The sources highlight a specific product called Desereal Plus.
Okay, so it's not just a generic facial filler.
No, definitely not. It has a unique rheology, which means how the gel flows and deforms under pressure. It has a high elasticity, or G-prime.
Because it has to withstand a lot.
Exactly. It's engineered specifically to withstand the intense shearing forces and compression of sitting, walking, or running without, migrating or flattening out into a pancake.
Wow. And the clinical guidelines emphasize strict volume limits on this, right? The protocol suggests a maximum of 20 milliliters of cross-linked HA per person per year.
Yeah, because the tissue has a physiological capacity limit. You can't endlessly pump thick gel into a confined anatomical space.
You compromise the local blood supply, right?
Exactly, or stretch the delicate mucosal tissues to the point of permanent damage.
Okay, so let me push back a bit. If someone knows they're signing up for this top-up treadmill, knowing they have to return to the clinic every 8 to 12 months just to maintain their baseline volume, why not bypass the gel entirely and opt for a permanent surgical fix from day one?
It's a great question, but the psychological barrier to permanent alterations is massive. Filler provides the ultimate try-before-you-buy approach.
Oh, I see.
Because surgery carries systemic risks, anesthesia considerations, and, permanent aesthetic commitments. Fillers let the patient evaluate if restoring the volume actually resolves their mechanical chasing and pain.
Without making a lifelong commitment.
Right. And the most crucial factor driving that decision is reversibility.
Oh, right. Because what if they hate it?
Exactly. Let's say the patient gets the HA filler and hates the result. Maybe it feels unnaturally firm, or it just doesn't relieve the physical discomfort. The clinician can simply inject synthetic hyaluronidase directly into the area.
The same enzyme that breaks it down naturally.
Exactly. That enzyme floods the tissue, immediately cleaving those glycosidic bonds holding the cross-linked mesh together.
Wow.
The thick gel dissolves into a liquid and is flushed away by the lymphatic system within hours, returning the tissue to its original state.
So it's an unparalleled biological safety net.
Yeah, exactly.
But, for the patients who love the result, constantly watching the clock for their next top-up appointment eventually gets exhausting.
Oh, absolutely. They want off the filler treadmill.
Which brings us to the alternative path, the investment model. If you don't want a synthetic temporary gel, you use your own tissue. Autologous fat grafting.
Right, and biologically and surgically, autologous fat grafting is a fundamentally different undertaking.
So this procedure relies on microliposuction.
Right.
To harvest fat from a donor site on the patient's body, usually the lower abdomen, the flanks, or the inner thighs.
Yeah.
And the surgical team takes that harvested fat, puts it in a centrifuge to separate the viable living fat cells from the oils and dead cellular debris, and then carefully injects those purified living cells into the labia majora.
Right, and it is pitched heavily in aesthetic circles as the permanent solution.
The permanent solution.
But when you actually look at the clinical data, the concept of permanent requires a massive asterisk.
Right, because when transferring fat, the surgeon isn't moving an inert substance like a gel. They are transplanting millions of living, metabolically active cells.
Exactly, and for those adipocytes to survive in their new location, they desperately need oxygen and nutrients. They must physically plug in to the local vascular network.
I was thinking about the mechanics of this, and it's a lot like trying to transplant a fully grown tree from one yard to another.
Oh, that's a perfect way to look at it.
You can't just stick the root ball in a new hole in the dirt and assume it's going to thrive.
Right.
Those roots have to aggressively grow out and tap into the local water supply, like the surrounding soil moisture, almost immediately.
Right, or it dies.
Yeah, if they don't establish that connection within the first few weeks, the tree starves.
And the exact same principle applies to fat grafts through a biological process called angiogenesis. The newly placed fat droplets secrete chemical signals demanding a blood supply.
They're basically screaming for oxygen.
Yes. And the surrounding labial tissue responds by sprouting new microscopic blood vessels capillaries that infiltrate the grafted fat.
But if those new capillaries don't reach the center of the injected fat droplet within a matter of days, the cells in the center undergo necrosis. They die from lack of oxygen.
Yep. And the body's immune system immediately recognizes this necrotic, dead tissue. Macrophages rush in, engulf the dead fat cells, and clear them away.
Wow.
And because this process of angiogenesis is a literal race against time, a massive number of cells just don't win the race.
Right. The clinical literature reveals that the body naturally reabsorbs between 30% to 50% of the transferred fat within the first 3 to 6 months.
Up to half. Up to half of the volume is just metabolized and swept away by the immune system.
That's incredible. You go through the surgical harvesting, the purification, the reinjection, and your body essentially just eats a massive chunk of the results.
It does. The unpredictability of living tissue integration is definitely the biggest hurdle in fat grafting. But there's this 2021 prospective cohort study by Bourne that provides incredible insight into this timeline.
Right, I saw that. They use high-resolution CT scans to track volume retention over time.
Yeah, in patients who underwent craniofacial fat transfer. And while the anatomical location was the face, the underlying biological principles of fat survival and angiogenesis applied directly to the labia.
So those high-res scans allowed them to measure the exact percentage of graft survival. And they found that volume retention averaged about 63% at the 9-month mark.
Which is pretty good.
Right.
But the predictive timeline was the real breakthrough in that study. The volume retention observed at the 3-month mark strongly predicted the final retention at 9 months.
Oh, so the first 90 days are the critical window.
Exactly. If a fat cell manages to establish a robust microvascular connection by month 3, it is stabilized and likely there for the rest of the patient's life.
Okay, but knowing that the immune system is going to aggressively clear out 30% to 50% of the injected volume, the surgical approach obviously has to account for that loss, right?
It does, using a strategy called intentional overcorrection.
Right.
The surgeon mathematically calculates the expected loss and purposefully overinjects the labia. They transfer significantly more fat than is actually required to achieve the patient's final aesthetic and functional goal.
So the patient wakes up from surgery looking significantly puffier than they wanted.
Yep. They leave the clinic knowing they just have to wait out the body's internal cleanup crew over the next few months as the volume slowly deflates down to the target size.
That has to require intense patient education just to manage the psychological impact of that initial swelling.
Oh, absolutely. But even with precise overcorrection, the integration of living tissue isn't perfectly controllable. So this permanent solution routinely requires its own form of maintenance.
Right, the secondary fat top-up.
Yeah. If the body's macrophages are particularly aggressive and absorb closer to that 50% mark,
Okay.
or if the microvascular network heals asymmetrically, leaving one side noticeably fuller than the other.
The patient has to return to the operating room.
Exactly.
Yeah.
For a secondary harvest and injection session.
And this secondary top-up is usually scheduled around the 6-month mark, right? Once the initial graft has completely stabilized and all the inflammation is gone.
Right. But the Bourne study noted a highly reassuring data point regarding this second session. Patients who underwent a secondary procedure experienced similar, sometimes even better, volume retention rates compared to their first procedure.
Oh, so the tissue remains highly receptive.
Yes, exactly.
It's so similar to planting a new lawn from seed.
Oh, how so?
Well, you intentionally overseed the dirt because you know the birds will eat a portion of it, and some seeds just won't germinate in the soil. You accept it won't be perfectly uniform on the first try.
Right, right.
But then, a few months later, once the grass is established, you survey the lawn and do a secondary top-up. You scatter more seed over the bald patches to achieve a perfectly even, dense result.
That is a brilliant analogy. It is a staged biological integration.
Yeah.
But, while dealing with the unpredictability of fat reabsorption and the potential need for a second surgery sounds daunting, autologous fat grafting offers a hidden physiological perk, something that makes the whole process worthwhile for many patients.
Right, because hyaluronic acid fillers, for all their convenience, simply cannot match the regenerative aspect of living tissue.
Exactly. The regenerative bonus is easily the most fascinating aspect of the clinical data. When the surgical team harvests the fat, they aren't merely collecting adipocytes, the volume-providing fat cells.
No, the purified tissue actually contains a highly active component called the stromal vascular fraction, or SVF.
Yes. And the stromal vascular fraction is basically a powerhouse of regenerative medicine. It is a dense, heterogeneous mixture of cells that includes endothelial cells, immune cells, and most importantly, adipose-derived stem cells.
Stem cells.
Exactly. When these adipose-derived stem cells are introduced into the labial tissue, they do so much more than simply take up space.
They act like biological architects, right? Actively surveying and remodeling the local environment.
Yes. They immediately begin secreting a cascade of growth factors, including vascular endothelial growth factor, which forcefully stimulates the creation of new blood vessels.
Oh, wow.
They also signal the local fibroblasts to dramatically ramp up collagen and elastin synthesis. This cellular activity restores intense hydration and elasticity to the mucosal tissues from the inside out.
And the clinical applications for this, especially for patients dealing with severe scar tissue, are profound. The sources detail how effective the SVF is at softening rigid, painful scarring from childbirth episiotomies, where a surgical cut was made to enlarge the vaginal opening.
Right, which leaves terrible scar tissue for some women.
Exactly. And it also shows remarkable efficacy for patients suffering from lichen sclerosis.
Yeah, lichen sclerosis is a chronic autoimmune-like inflammatory condition. It causes the vulvar skin to become incredibly thin, fused, and plagued by microscopic tearing.
It's agonizing.
It is. But the adipose-derived stem cells actively suppress the local inflammatory cascade and physically remodel the fibrotic, damaged tissue, restoring a much more natural, supple texture.
So the fat grafting isn't just a mechanical volume replacement. It is a profound cellular therapy that makes the entire biological neighborhood structurally healthier.
Exactly. But there's a massive lifestyle caveat attached to this investment model.
Right, there's always a catch.
Always.
Yeah.
Because the surviving fat cells are fully integrated living tissue, they adhere to the metabolic rules of normal body fat.
Right. The adipocytes grafted into the labia majora retain the epigenetic programming of their original donor site.
Yes. So if the surgeon harvested the fat from the patient's abdomen, those cells still think they are abdominal fat.
Wow. So if the patient subsequently loses 20 pounds, those specific fat cells in the labia will release their lipid stores and shrink, deflating the volume.
Yep. And conversely, if the patient gains significant body weight, the labia will grow proportionally.
The fat literally remembers where it came from.
It really does. It expands and contracts in lockstep with the patient's overall systemic weight fluctuations.
And this biological quirk is why maintaining a highly stable body weight is an absolute prerequisite for patients considering autologous fat transfer. You are entirely relocating a dynamic, metabolically active storage system.
Exactly.
So if you're weighing these options based on the clinical texts, the core takeaway really comes down to choosing between two distinct models of biological interaction.
Right. You can opt for the short-term convenience of the filler model. It offers precise, immediate results with the ultimate safety net of reversibility.
But it demands a rigid, ongoing schedule. You are committing to returning every 6 to 18 months to stay ahead of your body's natural enzymes.
Or you commit to the surgical investment of fat grafting. You leverage your own biology, you navigate the unpredictable 30% to 50% reabsorption rate, you likely undergo a secondary surgical top-up to refine the results.
But you benefit from the powerful regenerative effects of the stem cells.
Yes, but your long-term success is permanently tethered to maintaining a stable body weight.
Right. The deeper we look at the science, the more it highlights the incredible reality of human biology. The body never just passively accepts a physical change.
Never. It is constantly metabolizing, building new microvascular networks, rejecting necrotic tissue, regenerating cellular scaffolding.
Which leaves a truly fascinating question for you to consider as we wrap up today. We know that autologous fat grafts retain the specific metabolic memory of their donor site, right? Expanding and shrinking with your overall body weight.
Right.
But what happens decades down the line? As a person's systemic cellular metabolism drastically changes in their 70s or 80s, will this permanently relocated fat age at the exact same rate as the surrounding vaginal tissue?
Or will it forever act like a tiny, isolated piece of the abdomen, stubbornly playing by its own metabolic rules, just living somewhere else?
Exactly.
The long-term cellular destiny of grafted tissue is an incredibly complex frontier in regenerative medicine. It really makes you think.
It definitely does. Something for you to mull over. Until next time, remember, whether we are talking about the structural integrity of a well-loved couch cushion or the complex biomechanics of human tissue, nothing stays perfectly stuffed forever. The reality is always dynamic. Thanks for joining us on this deep dive.